Well, welcome to part 2 of this presentation on the gastrointestinal system. And in this component we're going to be looking at the activity in the mouth and the stomach. Now, children have 20 so-called deciduous teeth, or sometimes called milk teeth, and adults should have 32 teeth, and they're all shaped to perform particular functions. The incisors at the front are chisel shaped to bite into food, for example cutting into an apple or a carrot. Behind these are the canines, which are pointed to stab into and tear food, such as tearing off a piece of meat. Canines, of course, are very prominent in dogs. Next there are the premolars, which crush and grind food, so are important in eating vegetables and grains. And finally, at the back of the mouth are the molars, which also crush and grind. The upper and lower jaw bones each have 2 pairs of incisors, 1 pair of canines, 2 pairs of premolars, and 3 pairs of molars. Teeth are lined with enamel, which is a very hard substance, and under this there's a bone-like substance called the dentine. The inner pulp cavity contains sensory nerve fibres, blood and lymphatic vessels. And teeth are described in 3 regions. The top part is the crown, under this is the neck, and the root is the part which connects with the jawbone. And teeth are firmly held in sockets within the jawbone by cementum and fibres of the periodontal ligament. So the periodontal ligament are these strong fibrous material holding the teeth into the jawbone. The bottom teeth are held in the mandible and the top ones in the maxilla. And all this is really important because it means that humans are omnivores. We can eat a very wide variety of foods, which of course increases our probability of surviving in difficult situations. Now, dental caries is a very common global health issue. Caries is actually Latin for rotten, so it just means literally rotten teeth. And caries occur in the presence of a bacteria called Staphylococcus mutans and dietary sugar. So if there's sugar in the diet, these Staphylococcus mutans consume the sugar and excrete acidic waste products. And although enamel is very tough, it can be dissolved readily in acid, allowing the bacteria into the dentine below. So ideally we want to remove the Staphylococcus mutans, and it's often easier to remove the sugar from the diet because the decay can get through the enamel, through the dentine, and once it gets into the pulp cavity and you get bacteria and inflammatory changes in the pulp cavity, this is excruciatingly painful. This is the pain of toothache and is one to be prevented if at all possible. Now, digestion occurs as a result of 2 processes. And in digestion, food molecules are broken down into simpler components which may be absorbed. And the 2 processes are mechanical digestion and chemical digestion. And by the end of the overall digestive processes, proteins are broken down into amino acids, carbohydrates into simple sugars, and fats into fatty acids and glycerol. Now, mechanical digestion is when food is physically broken down, and this starts in the mouth by the process of chewing. And the process of chewing is correctly termed mastication. So we are all masticators of our food. And once food is in the stomach, there are regular peristaltic contractions about every 20 seconds. And these are called mixing waves, muscular contraction of the wall of the stomach, the smooth muscle in the wall of the stomach. And these churn the gastric contents into a mixture called chyme. As chyme is peristaltically squeezed along the small intestine, it's subject to further mixing. And these physical processes break up and therefore increase the surface area of the food. And this gives a larger surface area over which bile and enzymes may subsequently act. Now, an enzyme is a biological catalyst. It will facilitate and increase the rate of a chemical reaction. And of course, there's enzymes that perform thousands of biochemical, physiological functions inside all the cells of the body. But the enzymes in the gastrointestinal tract all break down larger molecules into smaller molecules. And when there's a breaking down effect, we call that a catabolic effect. So they're all catabolic enzymes in the gastrointestinal tract, breaking down large molecules into smaller molecules. The digestive enzymes are produced by exocrine glands and act in the lumen of the gut. So, for example, in the mouth, the enzyme that used to be called ptyalin is now called salivary amylase. And the salivary amylase is an enzyme produced in the 6 salivary glands, the 3 pairs of salivary glands. The saliva passes out of the ducts of these glands into the mouth. And there the pancreatic amylase will break down polysaccharides, that is, starch molecules. And it will break it down into smaller disaccharide units. So here we see many sugar units on the left, and the salivary amylase will convert that into these much more soluble 2 sugar units called disaccharides. So di, of course, means 2. And you can prove this to yourself relatively easily that this happens. So if you eat a bit of bread or some starchy food and you leave it in your mouth for a minute or two, giving the salivary amylase time to break down the polysaccharide into disaccharide, then after a minute or two it will start to taste sweet, because the simple sugars, the disaccharides, taste sweet, whereas the polysaccharide, larger starch molecules, don't taste sweet. Now, saliva is continuously secreted into the mouth in small volumes to keep the mouth moist. But when we see or smell or taste food, this will increase the production by as many as 20 times. Indeed, if you're hungry or you can smell food, we sometimes say we're watering in the mouth. And secretion of saliva is stimulated by activity of the parasympathetic vagus nerve, this 10th cranial nerve. And the vagus nerve is itself under the control of 2 salivary nuclei located in the brainstem. Now, water is the principal component in saliva, but of course it also contains some sodium chloride, it's a little bit salty. And it also contains an enzyme which acts against bacteria called lysozyme. The mucus acts as a lubricant and a softening agent. And salivary amylase is the digestive enzyme, as we've said, that starts the digestion of carbohydrates by breaking starch molecules down into this disaccharide called maltose. Now, there is a separate video on swallowing, so I'm only going to cover it very briefly here. But the teeth close on food, and that has the effect of crushing it and displacing it. And the tongue, lips and cheeks repeatedly push the food back between the teeth for further mechanical processing. And during this grinding process, food is mixed with saliva and formed into a bolus. Swallowing, now that's correctly termed deglutition. So deglutition is the process of swallowing. And this deglutition occurs in stages. Firstly, the mouth is closed. Next, starting from the front, the tongue moves the food backwards along the palate, which forms the roof of the mouth towards the oropharynx at the back of the mouth. Contact of the food bolus with the back of the mouth initiates the swallowing reflex, and respiration is stopped as part of this reflex to prevent food being aspirated into the trachea. because that can cause choking and aspiration pneumonia. Now, return of food back into the mouth is prevented by the tongue, and food is also prevented from going up into the nose by the soft palate moving upwards. Movement of the epiglottis prevents food from entering the trachea. So during swallowing, the epiglottis flops down over the trachea to prevent aspiration. Next, the muscular walls of the pharynx contract, pushing the food in the only direction left open, that is into the esophagus. Now, the most common cause of choking is trying to speak and eat at the same time, because speaking involves movement of the vocal cords and inhaling air in order to exhale, to vibrate the vocal cords. So when you're eating, don't speak at the same time and you're less likely to choke. The esophagus, or food pipe, is a muscular tube which extends from the laryngopharynx down through the chest. So the pharynx is in three stages: the nasopharynx at the top, then the oropharynx, then the laryngopharynx. And the esophagus is a continuation of the bottom part of the laryngopharynx. And the esophagus goes through the thoracic cavity, and it passes through the diaphragm into the abdominal cavity where it joins the stomach. The esophageal lumen is lined with a stratified squamous epithelium. It's stratified because it has to cope with a certain amount of wear and tear as it swallows food material. And mucus is secreted from this lining to lubricate the passage of food. Once a food bolus enters the esophagus, peristaltic waves of contraction in the muscular wall propel the food down towards the stomach. At the bottom end of the esophagus is the lower esophageal sphincter, also called the cardiac sphincter because it's vaguely close to the heart, and this regulates the passage of food into the stomach. This sphincter is located in the terminal 4 centimetres of the esophagus and is normally closed. After swallowing, the lower esophageal sphincter relaxes for about 8 seconds to allow the bolus of food through into the stomach. Then it contracts again to prevent regurgitation, because we don't want the material from the stomach getting back into the esophagus. If acid contents from the stomach do reflux into the esophagus, then we get heartburn. And evidence for the peristaltic action of the esophagus is seen in the ability to swallow when we're lying flat, or I wouldn't recommend it, but we can actually swallow when we are upside down, although normally gravity does assist this process. Now, difficulty in swallowing is called dysphagia and may be caused by diseases of the mouth, tongue, or neuromuscular disorders of the muscles and the nerves controlling the process. There can be esophageal disorders, such as esophageal cancer, or foreign bodies can also cause difficulty swallowing. And it can also be a psychological issue that can lead to dysphagia as well. If food enters the airway when an individual is conscious, that will lead to choking. So we don't want to inhale food into the airway because that will make us choke. And as we've said, the most common cause is eating and speaking at the same time. Now, in unconscious patients, this is particularly important, because unconscious patients are unable to swallow if they're given anything by mouth. So if a fluid or food does go into the mouth of an unconscious patient, it will simply run down into the lungs, causing aspiration of the food or the fluid, leading to aspiration pneumonia, which is a life-threatening condition. So obviously we never give any food or fluids to patients with a low level of consciousness, and certainly not to a patient who is absolutely unconscious. The stomach is a widened area of the gastrointestinal tract, and it expands when it fills with food. And the stomach receives, stores, mechanically and chemically breaks down food. And finally, it controls the release of gastric contents into the first part of the small intestine. And this gastric emptying is regulated via a second ring of muscle called the pyloric sphincter. Now, gastric is the word that means to do with the stomach. So anytime you hear gastric, it means to do with the stomach. Now, the proximal, that is the first part of the stomach, has a relatively thin wall and is highly distendable, allowing it to store an ingested meal. Whereas the distal, the lower part of the stomach, has a thicker muscular layer, and there is a greater level of peristaltic activity in this distal part of the stomach to churn the contents. And anatomically, we can see the stomach is divided into areas. So we've got the esophagus and the cardiac sphincter. The top part of the stomach is called the fundus, that is proximal. The body is the middle part of the stomach, and the distal part is called the pylorus. And the pyloric sphincter regulates the passage of material from the pylorus, or the pyloric area of the stomach, down into the duodenum, which is the first part of the small intestine. Now, it's necessary to physiologically regulate the activity of the stomach, so we need to think about gastric regulation. And nerve signals from this 10th cranial nerve, the parasympathetic vagus nerve, increase the secretion of gastric juice. So it's the vagus nerve that stimulates the secretion of saliva from the mouth and the secretion of gastric juice. And in addition to this neuronal level of control, when we eat proteins and there's protein present in the stomach, this initiates the secretion of gastrin from specialised mucosal G cells located in the gastric pits, as we'll see slightly later on. Now, gastrin is an endocrine hormone which circulates in the blood and stimulates the chief cells to secrete more pepsinogen and the parietal cells to produce more hydrochloric acid. So the presence of protein in the stomach therefore stimulates the secretion of the digestive agents necessary for its own digestion. And when there's no protein in the stomach, the levels of pepsin and hydrochloric acid are comparatively low. And this mechanism reduces the volume of gastric juice when the stomach is empty. And this is important because it helps protect the lining of the stomach from the potential harmful effects of pepsin and hydrochloric acid. Now, histamine is also produced by the gastric mucosa, and parietal cells are able to detect this chemical via histamine 2 receptors, so-called H2 receptors. Histamine stimulates the parietal cells to produce more hydrochloric acid. So if we're able to inhibit the H2 activity, we'll reduce the amount of hydrochloric acid produced by the gastric mucosa. And drugs such as cimetidine and ranitidine reduce gastric acid by blocking this H2 receptor site on the parietal cells. And this promotes in the healing of gastric ulcers and duodenal ulcers, any form of peptic ulcer really, because it reduces the amount of corrosive hydrochloric acid in the gastric secretions. Now, the stomach is internally lined with gastric mucosa, and this lies in large folds called rugae when the stomach is empty. And these are important because they increase the surface area of the stomach to allow it to expand after meals. And the gastric mucosa is lined with simple columnar epithelial cells. And when we look closely at the gastric mucosa, we see that there are numerous gastric pits which project down into the mucosa. And these pits contain the gastric glands, which make the gastric juices. And actually the gastric pits are lined with several types of specialised exocrine cells, which secrete the various types of gastric juices. Now, gastric juices are also referred to as peptic juices. So gastric juice or peptic juice is actually the same thing. Now, around the neck of these pits there are numerous mucus secreting cells. And this of course is essential because the gastric mucosa is just that, it is a mucosa, therefore it's lined with mucus. And this is essential to protect the stomach lining from the irritating effects of the other gastric juices. If the mucosa is disrupted, a gastric ulcer can result, as gastric juices attack and digest the underlying tissues. So gastric ulcers are actually a type of peptic ulcers because they're caused by peptic juice. If you get regurgitation of peptic juice into the esophagus, you can get peptic ulcers in the esophagus as well. There'll be esophageal ulcers, but they're still peptic ulcers because they're caused by peptic juice. And it's the same in the duodenum. You can get duodenal ulcers, also caused by peptic juice. So you can get peptic ulceration of the duodenum. But it's essential we have this mucus to protect the lining of the stomach. Now, next we want to look at what these pits contain in more detail. Now here we're looking at one of the gastric pits, but in higher magnification. And I think you can see that there's two extensions down from the gastric pit, and these are called tubular gastric glands. And they're lined with secretory glands producing exocrine products. Now the most common type of cell in the pits are the chief cells, also called zymogenic cells. And these produce the enzyme precursor called pepsinogen, which travels out of the gastric pit into the lumen of the stomach, where it will be converted into active pepsin. The parietal cells, also unfortunately called oxyntic cells, secrete the hydrochloric acid, and they also excrete what is called the intrinsic factor. In the old days, this was called the intrinsic factor of Castle, and it is essential for the absorption of vitamin B12. So this factor combines with B12 to allow it to be absorbed later on in the gastrointestinal tract. Now the G cells secrete an endocrine hormone called gastrin directly into the blood. So the parietal and the chief cells are exocrine, secreting cells out into the lumen of the stomach. But the G cells are a little unusual. They are endocrine in nature, producing this gastrin regulatory hormone. And we can see that this whole gastric pit is in the gastric mucosa, just on top of the muscular layer of the mucosa. Now, as you might expect, there's two components to digestion in the stomach, mechanical and chemical. So after a meal, there's slow peristaltic waves at the rate of about 3 a minute, passing down the length of the stomach from the top towards the pyloric sphincter. And this muscular peristaltic activity helps to mix the gastric juices into the stomach contents. As a peristaltic wave nears the pyloric sphincter, the sphincter will contract, so that only a small amount of fluid containing small food particles and fluid will be squeezed through into the duodenum. And this is important because it means that it prevents dumping of material in the duodenum before it is sufficiently digested to pass on from the stomach into the duodenum for the next stage of digestion. Once in the lumen of the stomach, pepsinogen, which is an inactive proenzyme, is converted into the active proteolytic enzyme called pepsin. Now, lytic or lysis means to break down, so a proteolytic enzyme will break down proteins. And a protein is made up of long chains of individual amino acid units joined together by peptide bonds. So pepsin starts the process of protein digestion by breaking peptide bonds. And the result is shorter lengths of amino acid sequences called peptides. Now, normally all enzymes end with the suffix ase. That's how you recognise an enzyme, it ends in ase. But the problem is pepsin was discovered before this convention was adopted. So it's an exception. Now, in young children, the stomach also secretes renin, and this enzyme coagulates milk into a curd to prevent it running through the stomach before it has been acted on by pepsin. And once chemical digestion has occurred, the combination of gastric peristalsis and activity of the pyloric sphincter will move partly digested chyme into the next stage, which is the small intestine. And chyme is the name given to the combination of partly digested food mixed with digestive juices. The rate of gastric emptying varies between 2 to 6 hours depending on the nature of the food. So after you've eaten, the stomach could be emptying as little as 2 hours, or as much as it could be as slow as 6 hours. Now, liquids pass through the stomach more quickly than more solid foods do. Carbohydrates pass through the stomach fairly quickly, but foods containing protein take longer. And emptying is slowest after meals which contain a lot of fat. And the rate of stomach emptying is limited by the rates at which the small intestine can process particular types of food. So you might have noticed that if you have a nice fatty breakfast with bacon and eggs and some fried bread and fried mushrooms, you can feel full till well after lunchtime. But other times, if you eat meals which are rich in carbohydrates, for example if there's a lot of white rice in your meal, it's quite possible to feel hungry a couple of hours later. And this can be explained partly by the rates of gastric emptying, because when the stomach is full, you're more likely to feel satiated, and when the stomach is empty, you're more likely to feel hungry. Now, we want the pepsin to digest the proteins in the lumen of the gut, in the stomach, but we don't want the pepsin to digest the proteins that the stomach is made of. So for this reason, the pepsin is not produced as the active proteolytic enzyme pepsin, it's produced as a precursor, pepsinogen, and this is inactive. It's only when the pepsinogen gets into the lumen of the stomach, into the acid environment, that the hydrochloric acid will convert inactive pepsinogen into the proteolytically active pepsin. And as well as this, there's a 1 to 3 millimeter layer of alkaline mucus lining the stomach that protects the stomach wall against the acidic and proteolytic contents of the lumen of the stomach. But if the mucosa, or the layer of mucus on the mucosa, is disrupted, then the peptic juices can get through, causing peptic ulceration. And as we've noted before, this can cause gastric peptic ulcers or duodenal peptic ulcers if this mucosal barrier is disrupted for any reason. But normally it's protected by the fact that the enzymes are made as pre-enzymes before they're activated in the lumen. And we'll see further examples of this when we consider the proteolytic enzymes produced by the pancreas in inactive form that are only activated when they get into the lumen of the duodenum. Now, before we pass on from our considerations of the stomach, I'd like to think a little bit about vomiting, or emesis. So emesis is a natural defense mechanism to remove infected or poisonous food from the gut. Irritation or distension of the stomach sends nerve impulses to the vomiting centre, which is located in the medulla oblongata, which you might remember as the lowest part of the brain stem. And it's the vomiting centre which controls the vomit reflex. So this is all quite deliberate. This is designed into the very structure of the nervous system to allow us to be able to vomit. Initially, there's retrograde contraction of the small bowel, an antiperistalsis. So material which has gone into the small bowel is going to move back by reversal of the peristaltic waves. And this antiperistalsis propels the contents of the small intestine back into the stomach. Once the material to be expelled or vomited out is in the stomach, there is a forceful inspiratory movement with the epiglottis closed. And this causes the diaphragm to press down and increase the pressure in the abdominal cavity. At the same time, there's contraction of the abdominal wall muscles. And this effectively squeezes the stomach between the abdominal wall and the diaphragm. There's also contraction of the muscular layers in the wall of the stomach, and simultaneous relaxation of the lower esophageal sphincter, and antiperistalsis in the esophagus. So the stomach contracts, the esophageal gastric sphincter relaxes to allow the material to get back through, and there's antiperistaltic waves in the esophagus to propel the material up the esophagus. And these effects cause gastric contents to be forcefully ejected through the mouth. And this is good, it's getting rid of infections. If we weren't able to vomit, bacteria in the stomach can double in number every 20 minutes to half an hour, potentially making us much more ill than we otherwise would have been. So vomiting is an important defence mechanism. Now, sometimes in healthcare we do give drugs which are antiemetics, and these have a place, but generally we should not give these in infection because we want the infection out, and that is exactly what vomiting facilitates for us.